Now, let's talk about the monoamine hypothesis. So we left off talking about the role of norepinephrine in depression and how some treatments for the role of norepinephrine actually target all monoamines. Now, why is that? That's because of this thing called the monoamine hypothesis. So this hypothesis says that depression is a result of functional deficit of the neurotransmitters norepinephrine and serotonin at specific synapses in the central nervous system. So we're going to bring it up here when talking about norepinephrine. We will cover it a little bit again when we start talking about serotonin later, because these are the two main neurotransmitters involved in this monoamine hypothesis. So what this monoamine hypothesis says, again, is that it's the monoamines that are involved in depression, that a lack of these monoamines leads to depression. So the very first antidepressant ever made was a monoamine oxidase inhibitor, an MAOI. This drug was called ipronisad, and it was actually developed to be an anti-tuberculosis drug. However, people found that it actually helped boost mood as well, and that's why it started being used as an antidepressant. Now, how it works is an MAOI leads to more monoamines in the synapse by inhibiting their breakdown, as I mentioned before, and by leading to have more monoamines, this leads to an increase in our what we call monoaminergic neurotransmission. In other words, we have more binding of monoamines to receptors. Now, the most common MAOI that's used clinically was phenolzine. However, we don't use phenolzine anymore due to this thing called the cheese effect. Pretty much if you eat too much cheese when also taking certain MAOIs, it can lead to some very negative side effects. And rather than telling people you just can't eat cheese, we've developed other types of antidepressants instead. So the second kind of family of antidepressants is a tricyclic antidepressant, or a TCA. So these were good because you don't get that cheese effect, so you can still eat cheese, which I personally love. But it has its own problems as well. But a bit of history. So this was first developed in the 1950s from some chlorpromazine analogs. And so one of these drugs, imipramine, so that's the name. More common name would be tofranil. And what it does is it inhibits both norepinephrine transporters and serotonin transporters. So it prevents the reuptake of these two transporters. So it acts kind of similar to MAOIs. You get kind of the same effect, but here we're blocking the reuptake, whereas with MAOIs we're blocking the breakdown. Okay. So again, impaired reuptake leads to more neurotransmitters in the synapse, which means we get prolonged and increased postsynaptic activity. Now, we do get some side effects on our muscarinic receptors. So these are because they're anticholinergic. So we see that they are actually parasympatholytic, which means it gives us symptoms similar to the parasympathetic nervous system. So we see dry mouth, constipation, and urinary retention. It's opposite to the parasympathetic nervous system. You know what I mean. Now, one problem with TCAs is that they have a very poor safety margin. And it actually induces mania at higher doses. So you don't get the cheese effect as you get with MAOIs, but they're less safe. So TCAs, again, are not used as often anymore because of their very poor safety margins. So today, you're going to hear more about people being prescribed these types of drugs called SSRIs or SNRIs. So SSRIs are selective serotonin reuptake inhibitors, whereas SNRIs are serotonin norepinephrine reuptake inhibitors. So based on the name, you can kind of guess what they do. Now, both of these drugs we call a second-generation antidepressant, and they both have a targeted drug design. So they really target specific things. So SSRIs only inhibit the reuptake of serotonin. These are some of the most widely used antidepressants right now. A great example would be Prozac, or its common name, fluoxetine. It selectively inhibits SERT, which we'll learn about in the serotonin videos. But what it does is it leads to more serotonin in the synapse. Now, SNRIs were made pretty much to replace TCAs because, like TCAs, they inhibit the reuptake of both serotonin and norepinephrine. However, it is much safer than TCAs. We have much improved safety margins and a lot less side effects. So they're much better now. Now, the first SNRI was more commonly called Effexor. This was in '94. Common name is venlafaxine. So venlafaxine is an reuptake inhibitor of both serotonin and norepinephrine. So again, what it means is that we're going to have more serotonin and norepinephrine at the synapse, which means it can act on the postsynaptic cell more. Now, there are some challenges to the monoamine hypothesis. In other words, there's some evidence that it's not just norepinephrine serotonin that leads to depression, right? So some challenges are that there's some pharmacological effects are very rapid. So we see that just by taking the drugs, if we were to then measure the amount of neurotransmitters in your system, we would see an increase very rapidly. In just hours or days, we'll see an increase in the neurotransmitters. However, our therapeutic effects are very slow, so it can take weeks or months to see the behavioral therapeutic benefits of taking these types of antidepressants. So the monoamines will normalize rapidly, but mood normalizes slowly. So that's why some people suggest that it's not just the monoamines that are causing depression. It plays a role, but it's not the only thing. There's also some demonstrated efficiency of drugs that do not affect the norepinephrine or serotonin reuptake. So, for instance, this drug, tianeptine, is a selective serotonin reuptake enhancer, so it actually increases the amount of serotonin being reabsorbed by the presynaptic cell, so that means there's going to be less serotonin in those synapses. And it's found to be just as effective as SSRIs in clinical trials. So why is it that a drug that decreases the amount of neurotransmitters is just as good as a drug that increases the neurotransmitters, right? So there's got to be something else going on. Also, cocaine acts as a norepinephrine reuptake inhibitor. However, it does not have antidepressant effects. So just by blocking reuptake of norepinephrine does not cause antidepressant effects. So you can see where there's a lot of these inconsistencies and why people are kind of questioning how good is this monoamine hypothesis. So this is just a study that kind of addressed this. It talks about the selective norepinephrine reuptake inhibitors. And so it measured how good multiple different types of reuptake inhibitors were. So norepinephrine reuptake inhibitors are not SNRIs, because SNRIs also block the reuptake of serotonin. So norepinephrine reuptake inhibitors are the SSRIs for norepinephrine. If that makes sense. It only blocks norepinephrine reuptake. Okay, so this is also a second generation type of drug. And a great example would be reboxetine, or Prolift is its a common name. But you're going to want to know the name reboxetine. And it selectively will block norepinephrine or norepinephrine transporters 20 times more than serotonin reuptake transporters. So it does block norepinephrine, not SERT. However, there have been a lot of questions about how good it is, about its safety margins and stuff, and so this is actually a drug that hasn't been brought to market in the US or Canada. So in the US or Canada, you're going to be prescribed with an SSRI or an SNRI rather than a norepinephrine reuptake inhibitor. So if we just look at ranking all of these are all antidepressants. Most of them are SSRIs or SNRIs, except for this one down here. This is reboxetine, which is that norepinephrine reuptake inhibitor. What it's measuring is the efficacy of these drugs. So the solid line is the efficacy, and then the dotted line is the acceptability, so who uses it and stuff. And there are ranks of how good they are. And you can see that reboxetine is pretty low, and most practitioners don't recommend it. So the rank is they asked a bunch of doctors to rank the efficacy of these drugs. So from 1 to 12, where would you rate them? And reboxetine was constantly placed in 11th or 12th place among pretty much everyone. So yeah, doctors don't like it. Doesn't seem to be great. So with this thorough systematic review, then people that took reboxetine actually had very, very few help with it. It didn't work very well. You couldn't tell the difference between patients that took reboxetine versus patients that took the placebo. So obviously it's not a very, very good drug if you get the same effects taking just a placebo. So that's why these norepinephrine reuptake inhibitors aren't prescribed as much, because they have such low efficacy, and they just don't seem to be worth it. Now, let's move on a little bit away from depression and into other things that norepinephrine plays a role in, such as attention disorders. So, norepinephrine reuptake inhibitors are psychostimulants. So, in the absence of activity at the dopamine transporter, prevents active effects of psychomotor stimulants, or cocaine. Sorry, that's supposed to be, it'll be fixed on your slides, norepinephrine. Okay, so the absence of activity at the norepinephrine transporter. So if we don't have reuptake of norepinephrine, then that can so pretty much if we have too much dopamine in the synapse along with norepinephrine, then the dopamine's actually going to kind of compete a little bit with the norepinephrine and prevent the addictive effects of, say, cocaine or some kind of psychomotor stimulant. And that's because both cocaine and a dopamine reuptake inhibitor do the same thing of they're blocking the reuptake, they're causing more neurotransmitter in the synapse, right? And we talked about before about how cocaine blocks reuptake of dopamine. So cocaine is blocking dopamine reuptake and norepinephrine reuptake. But blocking the dopamine reuptake can actually help prevent the addictive effects of psychomotor stimulants. So if you don't have the blockade of dopamine transport, but only blocking norepinephrine, then that's where you can see addictive effects. Now, of course, you can also get addictive effects. We talked about this with just dopamine as well. So noradrenergic drugs have been demonstrated to be effective in treating attention deficit disorders. If we take clonidine, right? So clonidine is a alpha-2A agonist, and what it does is it increases the amount of norepinephrine in the prefrontal cortex. So by increasing our norepinephrine, we're going to increase the attention in the prefrontal cortex. Now, another drug to treat ADHD would be reboxetine, which is, again, a NET inhibitor. We talked about that. So while it's not good as an antidepressant, it is a good drug to treat ADHD because, again, it's leading to an increase of norepinephrine in the synapse, where people with ADHD tend to lack the norepinephrine, the amount of norepinephrine that they need in their synapses. So both of these drugs will lead to more norepinephrine in the synapse, okay, which will lead to an increase in attention. It's thought to act to increase or prolong the norepinephrine signaling in the cortex, which again affects attention. So pretty much what I just said. Now, norepinephrine does contribute to opioid withdrawal. So withdrawal from opiates, so that would be like heroin, morphine, opium, will activate the noradrenergic system. Okay, so it will cause the noradrenergic system to turn on when it really shouldn't. And so this is responsible for some of those withdrawal effects you hear about, so like increased heart rate, elevated blood pressure, and diarrhea. Now, increased heart rate, elevated blood pressure, gee, that sounds like the sympathetic nervous system, right? Which we know norepinephrine plays a big role in. So it kind of makes sense that when you activate the noradrenergic system, you're going to see symptoms similar to the sympathetic nervous system. Now, it's the alpha-2 receptors that are targeted to treat the symptoms of opioid withdrawal. Okay, so the alpha-2 receptors, remember, are inhibitory downstream. So what they're going to do is they're going to turn off that sympathetic nervous system. So we've got clonidine, which is an agonist for the alpha-2 receptor. and it's used clinically to treat these withdrawal symptoms. And in the brainstem, then the alpha-2 receptor functions as a presynaptic autoreceptor on the noradrenergic cells. So it regulates the amount of norepinephrine that's released from its own cell. Okay, so activation will decrease the release of norepinephrine. So it's modulating how much norepinephrine is released. So what clonidine does is it acts on this alpha-2 receptor that's an autoreceptor, and it's telling it it's egging on the alpha-2 receptor. So the alpha-2 receptor is going to turn on. Now remember, the alpha-2 inhibits things downstream, so what it's going to do is it's going to then inhibit the release of more norepinephrine. And that's kind of how that works. It's kind of feedback system, right? Now another drug would be yohimbine, which is an alpha-2 antagonist that's been used experimentally to increase or provoke withdrawal symptoms. You could think of it, some people have been experimenting with these types of drugs so that when you take a drug to help someone quit, then when they take a drug, then they'll experience these withdrawal symptoms. Therefore, taking the drug becomes associated with negative things, so then the person will be less likely to take more drugs. So that's kind of the idea behind these drugs that provoke withdrawal symptoms. Right now, this is only used experimentally. It's not prescribed or anything. So finally, this is just looking at a graph of the use or how yohimbine is works. So when this is given through IV administration, so straight into the blood, then it works very rapidly because, again, it doesn't have to be metabolized, and it increases the severity of these withdrawals. So it will increase anxiety in the patients, sometimes to a point that the patients will actually have panic attacks. So if we look at this graph over here, we've got the amount of time since the infusion over here on the x-axis, and then the withdrawal symptom rating on the y. So the rating, as it goes up, it gets worse. In blue, we have the control group, so they were just injected with saline, and you can see their withdrawal symptoms, stay around like a 2 or a 3 the whole time. But with patients that were injected with yohimbine, then as time goes on, then when they're first injected, then their withdrawal rates skyrocket. So this looks confusing here, but pretty much it's just because from baseline to infusion, it needs to shoot up. They didn't measure anything in between here, so they just drew a line. But really, it might be more like, I'm going to draw. In real time, it'd probably be more like that. Okay, so infusion and then when it takes to work. But they only measured at these times. Anyways, let's continue. So with yohimbine, then their withdrawal symptoms seem very strong, or even worse, right after their infusion, and then it slowly, you can see how the yohimbine starts to get broken down and wear off. And then by about 120 minutes after infusion, then they're back to just normal withdrawal symptoms, which I'm sure probably don't feel nearly as bad anymore. But what the results of this suggest is that norepinephrine is involved in generating feelings of anxiety. So not just depression, like the monoamine hypothesis suggests, but also anxiety. And that makes sense because a lot of antidepressants are also used as anxiolytics. So that they don't just treat depression, they also treat anxiety. So that's it for norepinephrine. In the next videos, we'll start talking about our monoamine serotonin.